15 years of seeing study after study, the old conclusions are still there. New things are being proposed, but the same discussions and back and forth and negotiations are still ongoing. And I think the couple of things that probably stood out, and I can tell you this, something that I've seen in the practice myself, is that the sleeve gastrectomy has found a very strong ground. And so for the right patient, of course, any matched surgery is the right match. But the sleeve gastrectomy for a right patient, it's shown itself and its true value. And for those of you who are thinking about it and want to get more information, there's a whole gamut of literature on this on the American Society of Bariatric Surgery website. So kind of check it out. But the key with that operation, it's very important to recognize, is eating correctly. So with all of these, that holds true long term, but particularly with sleeve gastrectomy and the lap band patients. There was also a lot of allied health discussions this particular conference, and good nutritionist discussions and good psych discussions. And I'm glad actually Dr. Gatt is here because, I happened to sit next to somebody from the East Coast who was the main lecturer for Psych on this conference. And one of the things that he presented, and it really sat with me, he said, I have an office full of patients that come and see me desperate. They did everything they could. They lost weight, they plateaued, or they're not losing more, or they're gaining weight, and kind of depression sets back in, and they come to the nutritionist, they see the nutritionist, and then they go to the surgeon, and then he's the last port of call, So, and he really hammered it, I think, for me, is that he said, I tell these patients, there is no failures. It is just delayed success. And I thought that is so true. I mean, I never thought of it like that, And it's not that, we talk about 80% weight loss, 70% weight loss, but a big message in this conference was those are really just numbers. The true value of these operations is in how you feel after your weight loss. Okay, you have guidelines, but if you don't fall within that range, doesn't mean it was a failure. Majority of patients start to feel better. You start to improve in terms of your nutrition, your cholesterol levels, your blood pressure, your sugar control, and overall whole approach to life, your confidence level, your demeanor. But some feel that, they didn't get to the 80th percentile and they failed. And his message was that's not the case at all. And this was actually across the board. The surgeons talked about this, the nutritionists talked about this, that if you did everything that you knew was the right moves and you didn't get to that target value, but you're happy with where you are, that is great. And you should be very pleased with that, because had you not reached to that level, 5 years, 10 years from prior to your surgery, your risk of developing strokes and heart attacks and blood pressure problems would have gone up, and your certainly longevity is lower. The nutritionist had a lot of comments make about the points where patients reach a fullness versus reduced hunger. So, I mean, again, that's something that we all knew, but there is now a real emphasis on this, that they hammered this message home, that you do not eat really until you feel full. A lot of you may not even feel hungry, and we encourage you, and that's important, to eat small portions, but eat your meals. But one of the messages that came through was that don't eat till you feel that fullness and then stop. Eat until you're done with the hunger. If you're not hungry, but you haven't felt that fullness, stop. Okay? That fullness signal is it's a line that kind of moves along and is not necessarily the same every time. And so you push yourself to that fullness margin, and that's when you kind of get into trouble. So if you're not hungry after you've taken 2 or 3 bites, then that's fine, you stop. But you can eat maybe another portion in 3 hours. So very important to recognize that difference, and it's very hard and it's very subtle. But eat small frequently. And so for some patients that experience this low sugar dips, particularly after bypass, that definitely is the way to approach it. Small portions, eaten regularly. Okay. As far as the longevity of these operations long term, still the literature supports that the bypass gives at 16 or 15 years about 60% sustained weight loss. With the sleeve, we have a 10-year data, about 50%, and with the band, somewhere around 40. So the band kind of crosses the line and then starts to dip a little bit. And band is a good operation for selected group of patients, but really has associated long-term problems with it. And there are videos after videos of this being shown. And the key with this is, with the band, don't push the envelope, okay? The ones who get into trouble, and there was a French paper that was presented, terrific results actually. And thank goodness, our own results so far, we haven't had any major complications with bands. But we also follow, if you like, and it's funny, two different programs, two separate parts of the world, but our approaches were very much the same, is that they don't push the band patients, okay? The key is not to overfill these bands and not to try and put you in a situation where you eat 1 ounce and you're full. That's not the idea. The idea is to limit how much you eat correct, to curb your hunger a little bit, but to give you a tool to utilize, but not to completely block and obstruct the passage. And so the patients who seem to get into trouble with the band are ones that their bands are too tight, and eventually they either erode through, or they slip, or the patients start to then feel that they can't utilize solids at all and start to blend everything and mush everything and drink liquid shakes to get the calorie they need, and they overshoot. And so now you have a situation where instead of eating 12 to 1400 calories, you're taking 1600, 1800 calories, and your band is very tight, but you're actually putting weight on. So this group had a very good success rate, and follow-up was the main thing. Regular follow-up with the band was critical. So
is drinking caffeine still contraindicated in terms of ulcers and
nobody actually talked about coffee.
Yeah, I've not heard anything
Yeah.
either way. So what do you tell me?
Okay, so the traditional teaching was that caffeine is not a good thing for various reasons. It's a stimulant, it's a diuretic, it's an irritant, can cause reflux. When I first started, you kind of try and be the bad police guy and be taskmaster and really press hard. And what I found, the patients really do what they want to do. I mean, the truth of the matter is, you can tell them what you want, makes me feel better, but at the end of the day, I have a very good example of it. One of my patients was having surgery, and something came up, and I can't remember, was it indigestion or something, and I asked about coffee. There was this like silence for a minute, and there was a look between the husband and the wife, and the husband's kind of just jumped in the middle, took the opportunity. Yes, she drinks 8 cups a day. I just said, oh my God, what? And then she because she shrank in her bed, and she knew well that she shouldn't have, right? So what I ended up saying to patients is that, look, really, and that's my approach for everything, is you got to have a balance. There's no point in me telling you never have coffee, because you're going to be miserable for those of them who like coffee. So 1 cup a day, the caffeine content of 1 cup a day, especially if it's dilute, is, I think, not going to be counterproductive. So I said to them that they can have it. Now, I think with that, majority feel that, okay, they can still have it. Of course, some they make the cup long and tall, and so they play tricks, and they play tricks with themselves. But I think the 1 cup rule, that's at least something that I feel patients handle well, doesn't give them problems, and they do well with that.
Is it common?
We really blend ourselves with our patients. We really feel, at least the way I feel, very connected. And your successes is our success. Your failures is our failures. But I do really believe that if you do all the right things, and I see this often enough to feel the comfort of saying it to you, if you do the right things and you make the right moves, you will succeed. And success may not be that 80 percentile, maybe a little less, maybe a little more, but you will. And if you're not getting there, there are often obvious reasons for it. I mean, the dietitians that talked about it, they said often the patients really underestimate their intake, or they think they had enough of something, or they had something they thought it was this amount, but when they really read the fine print, they realized that, oh wow, they missed out a whole bunch of stuff. And when you tally it all up, at the end of the day, they realize where their errors were. So really, if you are not making progress, go back, reboot, take a look at everything, and you will make progress. But no matter how many surgeries patients have, at the end of the day, you have to stick with the principles. Eat healthy, exercise, take your supplements, and stay committed lifelong. As long as you do those things, 99% of patients do very well. And for that 1 or 2%, I tell you, there's going to be stuff coming through. I mean, we know that there are neuroendocrine underlying problems, and if that 1 or 2% happen to be those groups of patients, there probably is some therapy coming through. Okay? But stay with it. Use people around you to help you. Go to the support groups. Follow up with your primaries. These are all really important. Don't just wander off on your own, feel embarrassed, not go for follow-up. So just keep at it.